Direction. I'm Dr. Rama Kumar. So I'm presenting on surgical outcomes of full thickness macular hole associated with concomitant retinal pathologies. Full thickness macular hole, most of the literature what we come across is about idiopathic macular holes, but we do see secondary macular holes associated with proliferative diabetic retinopathy, retinal vein occlusion, RRDs and myopia. Especially myopia, RRDs are like more often we do come across macular hole as the cause for the RRD, and also trauma cases. So the tractional forces of idiopathic macular holes are mostly related to the posterior vitreous cortex or the ILM, like relieving the traction from the ILM, which can result in closure of the holes. But here there are other what I can say proliferations which are there, which are acting in other pathologies. And also in cases of pathological myopia, the posterior staphyloма part also is there. So like successful removal of the vitreous and also the traction along with ILM, and whether ILM flap is placed or not. There are many factors that come into play when we do these cases. So we tried to analyze 20 cases of full thickness macular hole associated with other retinal pathologies, and it's a retrospective study. All the surgeries done by me, and we excluded idiopathic macular holes and like those which are specifically associated with epiretinal membranes other than the other pathologies. So out of the 20 cases, PDR was there with TRD was there in 4 cases. Retinal vein occlusion with fibrovascular proliferation was there in 3 cases, and Regman-Region's retinal detachment in 13 cases, out of which there were 6 cases with posterior staphyloма, actually, myopic. And all of them ILM peeling and siliconyle as tamponade was given. This is the most important point of my presentation, that I had gone for siliconyle as the tamponade in all the cases. So out of them, type 0 was like they didn't close in 6 cases, and in 10 cases type 1, the what we see as normal anatomical closure with continuity of the retinal layers was seen, and type 2 is seen in 4 cases where we could see some kind of a gliosis because of the ILM flap. So as we know from our literature, more than 90% success rate is reported in idiopathic holes, but we don't have much of literature specifically looking at secondary macular holes. There are studies which quoted that siliconyle as a tamponade is going to help more in these cases, but they looked at different causes in different published papers. But like we tried to club all the cases which were there, and my purpose of going for a siliconyle tamponade is that, like as I mentioned, there are many factors which are involved in macular hole formation also, and after the surgery closure also. So as a tamponade, a longer term tamponade, and kind of if the fill is good enough, a tamponade which is covering the whole area where a bursa kind of a thing is formed, or even a little space is left, the chances of relieved traction and also the space not available for the fluid to seep in, then the chances of closure increase in these secondary holes. That's what the purpose I thought, and I could see that most of the cases where the hole has closed proved this point. So this is what I wanted to conclude by saying that vitrectomy with ILM peeling and siliconyle tamponade is useful in achieving success in majority of these cases. I can show some of the cases where I had done. The most important point is that reopening also happens in some of the cases, especially in these cases where they had some kind of a contraction along with the fibrovascular proliferation. So these cases also, the chances of reopening also lessen if there is a tamponade for a longer term period. That's what I felt. So this is one case where Parolinis classification didn't come, only posterior staphyloma with, I don't know whether we have any pointer here. So though there were flat edges, it cleared well after what I can say ILM peeling and going for a siliconyle tamponade. And this one is having a macular BRVO with a traction inferior to the fovea, and yeah, thank you. inferior to the fovea, and after relieving the traction and with siliconyl tamponade, the hole closed well. And this is that stage 4A of Parolini's classification. You can look at the dates like 5th of January and 10th of January. So within, you can see the siliconyl meniscus also here. Though SRF was little, took more time, the hole has closed well on the second post-op day itself, and with siliconyl inside, this patient maintained well over a long period of time. After oil removal also, I had a 2 years follow-up of this patient, and it maintained well. This was a case of proliferative diabetic retinopathy with tractional schisis and related macular hole, and this patient regained almost 6/9 vision after the oil removal and cataract surgery. So this is a post-trauma patient with macular hole because of some pressure cooker vessel which has hit the eye, and this also were maintained well after the closure. So these are my references. Thank you.
I think you made a very strong recommendation that we should put silicone oil, which I personally feel that we have been doing all such cases from a very long period of time now, whether it is PDR, whether it is BRVO, usually there's a component of traction. Once the traction is released, you can give a gas tamponade. I feel most of them usually close, and there is very less chance that they will reopen. As far as myopic or MTM related holes are concerned, I feel in those cases you might still put silicone oil, but as such, I don't believe that, or I don't feel the need of silicone oil in cases with PDR or in BRVOs. That is my personal take on it.
Actually, I tried to look at the numbers only for that reason, because I had the feeling that gas itself is sufficient. But when I tried to shift, because after getting some heartbreaks, when I tried to fill, especially in those cases where there were definite proliferations, and even after removal of the ILM, I could see that the hole was not closing. So after, I thought after starting putting oil, I saw more success. So that's why I thought I should present my numbers over here.
So I think Dr. Rama, that's a good concept, but yeah. I think probably just, it would be wrong on my part to just comment upon the, just the macular hole pathology per se and the disease pathology that goes along with it. So I do, agree with Ashish that, sometimes in diabetics, I think putting in oil can really be disastrous to the other part of the retina. And
yeah, yes, I agree. We do take a call based on that.
The second point that I have with macular holes, and I mean, fine, if you have a retinal detachment along with the macular hole, definitely oil is something that is preferred as a pathology, but I don't think it's per se because of the hole, it's more because of the other retinal pathology. The only thing is that, we've also done this study, and there was, the concept of unexpected loss of vision with silicone oil, which has been there. So that basically talks about this slight film that kind of is there over the foveal area, and that kind of is like a sandwich between the, the foveal interface and the oil interface. And that basically the electrolyte imbalance caused in that area is the reason for RP atrophy. So I don't know whether putting oil in cases where the retina is attached and the retinal pathology per se, the other retinal pathology, especially in these kind of cases, the other retinal pathology probably would have done with gas only. Whether just putting oil for the macular hole, I don't know whether it's, it's very, very justified. Though I know it's a good concept.
Actually, I would like to bring your notice to one point that those cases where hole didn't close, when they go for second surgeries, apart from filling the hole with either a retinal tissue or an amniotic membrane graft or further ILM from the periphery and all these things, there are many papers which quote that putting oil is going to improve the chances of the hole closure also.
I do agree that. So that is what I'm saying. So your data does have a positive impact in the field, in the thing that in cases where I am a little more, probably confused whether I should use gas or oil, where the other retinal pathology requires it. With a macular hole, maybe yes, putting oil in your series and looking at your data, maybe using oil, we should not
maybe
shy
more
away.
Numbers will give us.
But definitely in a case where probably oil is not required for the rest part of the retina, I don't know whether just putting oil for a macular hole would really be. I don't know. Still, I think
that's what
maybe
I
more
wanted
data
to
will
maybe
answer
more
that
data will be more
I
more
think
fruitful.
maybe next year you can come up with the
Yes.
comparison group of
Yeah,
gas
but
versus
very
oil.
We'll try.
encouraging.
Yeah.
So
Thank you.
Thank you.